Okay, again, good afternoon, everybody. So I'm with Dr. Gerald Werner, Mohammed, Xona.
Go to the first.
Doing the case of 62-year-old gentleman who is 65 kg, hypertensive, hyperlipidemic, diabetic. So he presented with angina, class 2 to 3, ECG normal sinus rhythm. He has some changes in T waves and the anterior leads, echo, preserved systolic function, U score 1.5, syntax score 24.5, JCTO score for to the LAD is 1. I don't think it's 1. I think it's 2 because calcified and long lesion.
Long lesion?
Yeah.
Severe calcium?
Yeah. So it's 2. If not 3, because it's,
no, it's
yeah,
2.
Yeah. Target lesion was supposed to be CTO LAD, followed by right coronary artery and or left circumflex stenosis. So if we want to go to the LAD retrogradely, so we need to fix the RCA first. This is what we did.
First of all, the CTO score, the syntax score, is a little bit low. I would guess this is much higher because this is 3 vessel disease all the way. So can you show the angio?
Yeah, this is it.
So you see this is the first shot. We didn't inject into the left main and did a dual injection, but you see there is a conus branch going to the LAD. So you see the LAD, and because there was the likelihood, because of the length of the lesion, that we have to go retrograde, we had to fix the right, also for contralateral injections. So this is a Chutkin's right 7 French with side holes. There was nothing much to this. It was easily dilated with 3.0. The 3.0 balloon expanded well, so there was, despite calcification in the wall, there was no need for rotablation or anything. So we did dilate with 3.0, both lesions, and then it was a little bit troublesome. Next, I needed a body wire to get the signs 4.023 into the middle lesion, and then you see the expansion, and then we did the ostium. This is already the ostial stent deployed. After this, we went with a 4.5 non-compliant. Next. This is probably the non-compliant inflation here. You see calcium, it's an aortio-ostial lesion with calcium in the aorta, like a renal disease. Yeah. I hope it stays open. But again, the expansion was very easy, so we didn't do rotablation here. Next. So this is now the first shot to evaluate the lesion. Maybe you stop, back a little bit. So this is a 7 French EBU with side holes, homemade side holes, maybe not big enough. Despite this, he has dampening. So we put a wire into the circ. You see the circ has also a high-grade lesion. And you see the ostial LAD with a notch. And you see that the lesion is about 25-30 millimeter length with collaterals from the septum. So let it run. Let it run. So that was the situation. We wanted to do IVUS for the left main, but it was evident that the left main is diseased, so IVUS was engaged with Alexandre. And I wanted to use the Volcano here because I wasn't sure whether we use it long for guidance or whatever. So in the meantime, what should we do? George, let's have a discussion. We already did something, but there are always many options. Would you go primarily retrograde, or would you try antegrade? The question with the Gaia one, would you need a secondary bend then on the Gaia? Okay, I tried with a field XT to explore next, but supported with a fine. We put a wire in the circ, always to push out the guide because he had dampening. So the field XT really didn't make any progress. No catching of the cap. Stop, stop, stop. We are going too fast. Go back.
Because I was driving.
Go back. The next choice was ultimate. And then ultimate didn't catch any tissue, and I couldn't advance the fine cross. So I chose the Gaia 2, first without a bend, which was even with intubation with the guide not helpful. So I did exceptionally a secondary bend. And this is the Gaia 2 with a secondary bend. It grabs tissue, and when the distal wire grabs something, then you have a chance. Yeah, but you needed the tapering. The sound goes down. So you see the fluoro sequence here? Next. So we made progress. I could advance the fine cross a little bit. I just show you the fluoro sequences, one after the other. Now, I still work with a kind of damaged Gaia, but it seemed to work here. Until, wait, until it's at the end of the sequence. So at one point we need the contralateral injection. Next. So we were not quite sure where we are, but it looked like we are in the right direction. So I advanced the fine cross. Next. We took another projection here. And this is already switched to a fielder XT back. So I did step up, step down. This is fielder XT. We see the calcium. And next, the wire moved rather easy now. Next. Here you see the fluoro sequence of the wire movement of the XT. And this doesn't look like subintimal. Now it enters a septal. Next. And to make a long story short, we were in. And finally, I managed to get down to the LED. Next. This is getting first always in the diagonal, septal, and now there will be, now we are in the LED. Next. Okay, this is the situation now, and then we did IVUS because IVUS became available. And Stefan will show the IVUS run from the circ towards the left main.
We are all the way down in the circ at this level, and we see that there is a lot of disease. At this level, we are still in the
small
circ.
balloon. What kind of good balloon do we have?
This is a 4 millimeter vessel, media with a lot of superficial calcification. Now, if we come back to the left main, we will see the wire coming. If you look at 1 o'clock, this is where you see the LED coming and the wire that is in the LED. Do you see it here? Now we have...
If I may interrupt, in this
Sure.
position probably, if I would have done live IVUS, It wouldn't help much because the cap is too far away from the IVUS. Yeah, because there is the notch.
Now we are in the left main that we measured. At this level, it was 5 millimeters square, which is not enough for a left main. And this is media 5 by 5. The proximal LED itself is a 4 millimeter media, and a 3.5 millimeter for a stent would fit, so no problem.
So my personal way would be now first to put a stent in the proximal circ, because the circ ostium is free, I think.
Yes.
Yeah. So we treat the lesion in the circ and then cover the left main towards the LED. And hope to avoid ostial circumflex stenting. Just open up the struts towards the circ. Okay, so not so spectacular, but I think the result hopefully will help the patient who was symptomatic on the table every time the left main was engaged or the right was dilated. This is the result after science 3023 expanded to 35 non-compliant. Looks good. And now we pass the LED with a Sapphire 125. And I was about to increase the size to 20 by 30. And then we can do IVUS. Okay. I think I should remove the Fielder XT and replace it by a BMW or something. Because even though it's a soft wire, it is tapered. The dimension, how to size the stent, especially proximal to distal, that's what I want to learn from IVUS. Go up. And now go to ariocaudal.
12, 14.
Show me. So, okay. And anyway, IVUS is on the table, well, for...
Highlights. Thank you.
But I think it's very difficult to size. We know the proximal size, 4.0, but where do you start to taper?
At this level, it's a 3 millimeter media.
Yeah.
A lot of calcium, superficial, some negative remodeling, and now more positive. We have a proximal LED that is
huge.
4.
There is some extreme positive remodeling there.
Yeah.
Okay. Maybe we could end with a stent at the LED ostium and leave a gap for the for the bifurcation.
You don't have to cover the ostium of the circ.
Yes.
That segment is normal, and the lesion was in the ostium of the
I just lost my circumflex wire. We like the patient. He likes us. He feels good. We are kind of in a perfection mode. Let's go back, or just show the last picture. Yeah. So you left us when we were planning to do the stenting, I think.
Go down. La.
The circ stent, yes, okay. Then we did, according to IVUS, the sizing of the stent. We leave it here. So go back a little bit. Let's see. Okay, so we put 2528 science right where the second diagonal takes off, and proximal 3538 until the ostium. And then we post-dilated everything, and then there was one problem. There was a notch here after post-dilatation distal. You see that if you run. And we were doing low-pressure inflation, and finally we ended up putting a small other stent there. Next shot. In the meantime, Stefan was evaluating, so this is the final stent there, okay?
Next.
Next. And this is,
No,
okay,
but
the
we didn't
store.
do.
We don't see the stores.
Okay.
Maybe we are too quick. Stefan did an assessment of the left main, and let's see the IVUS. Maybe in the bigger screen, the IVUS.
Okay, let's go this way.
So
AB color.
it was a 3.538 millimeter stent from the LAD to the ostial left main, and we are now coming back in that stent. We are in the proximal LAD, and at this level you see the SIR coming, and you will see some stents struts from the circ. So we are covering completely the ostium of the circ that looks well open, and now in that part you see that the left main needs some post-dilatation, what was done with a 5 balloon. Then we took a 4.5 millimeter balloon to post-dilate the LAD. Going back to the distal LAD, you see that landing zone was a very small target, 2 millimeter. And we don't see the lesion that needed to be stented finally, but more proximally in that LAD, the 2.5 stents was also too small. So we took a 3.0 balloon at that level. And the final idea is to now do kissing, circ, and LED.
We have rewired with a pilot. I just try where the balloon goes easily, but maybe I have hit the wrong struts, but there's also a way where you can overdo it.
Yeah, it went through.
Okay. So this is, now we do kissing.
Go up.
Okay, go up. We increase the place in the struts, and then we go with a fresh 3.5 non-compliant.
3.5 12, non-compliant.
So the result overall is, I think, like surgery.
No, give me the fresh new one.
New one?
Yes. 3. Okay.
So we have put, all in all, 6 stents. I hope that doesn't ruin the hospital. The surgeon, because he has no work. I think this would be a reasonable surgical case.
Do you want us to go to put
Yeah.
4.5 balloon in the LED now? 4.5 balloon in the LED now while waiting for 3.5?
We already did.
For kissing.
Ah, okay. Yeah, the 4.0, the 4.0. Yes, I would talk to this patient because he has good targets for the surgeon. That's always the question. Does he have a good target? And he would have good targets. And so we need to address this. And if the patient then refuses, then we go for surgery, for PCI. Yeah, we just do the kissing balloon, but you saw the final picture already. It will look just... So this is how it will look.